Now, sodium is the primary extracellular cation, accounting for about 90% of extracellular fluid and electrolytes. Normal levels are 136 to 145 milliequivalents per liter. Sodium will pair with chloride and bicarbonate to maintain electrical neutrality. And it's the most important ion for regulating water balance and is critical for nerve transmission and muscle contraction. Because of its central role, even small sodium imbalances can cause major clinical problems. Sodium levels are kept relatively constant through a balance of intake and renal excretion, and several hormones help to regulate this process. Aldosterone promotes sodium retention, antidiuretic hormone, or vasopressin, signals water retention, and the renin-angiotensin system, or renin-angiotensin-aldosterone system, the ROS, stimulates both. On the other hand, natriuretic peptides promote sodium excretion. So together, all these systems tightly regulate sodium and water to maintain blood pressure and fluid balance. And this is showing kind of the complexity of the hormonal systems and how they interact to regulate sodium and water. And if we have one system that becomes disrupted, such as maybe ADH deficiency and diabetes insipidus, sodium will rise. If another is overactive, such as an SIADH, sodium could fall. Understanding these pathways helps us identify the underlying causes of sodium disorders, not just the laboratory abnormalities. In adults and children and elderly patients, normal sodium levels, as I mentioned, are 136 to 145 milliequivalents per liter, with an optimal range that's a little bit tighter, 135 to 36 to 142. Critical values are anything below 120 to 125 or above 155 milliequivalents. Outside of these limits, patients are at significant risk for neurological dysfunction, seizures, and even death due to cellular dehydration or swelling in the brain. When sodium levels are too high, we call it hypernatremia. When they're too low, we call this hyponatremia. Both conditions are dangerous, as hypernatremia results when water loss exceeds sodium loss, leading to dehydration of cells. Hyponatremia results from too much water relative to sodium, causing cellular swelling. Because sodium is so closely tied to water balance, it's one of the most clinically significant electrolytes. Looking at some causes of hypernatremia when sodium's above 145, this can be due to excessive sodium intake or water loss. Causes: dehydration, burns, excessive sweating, conditions like Cushing's syndrome or other endocrine disorders like hyperaldosteronism or ADH deficiency, as seen in diabetes insipidus, could lead to this condition. In all cases, the cells will shrink, particularly in the brain, which leads to neurologic systems. And this is what you can see here, kind of the manifestation of hypernatremia. Clinically, you can see intense thirst, lethargy, or confusion. As brain cells dehydrate, neurologic dysfunction worsens, leading to seizures, coma, and even death in severe cases. Decreased vascular volume may also contribute to hypotension and shock. And the key takeaway is that hypernatremia is not just about sodium levels, it reflects underlying water imbalance and must be corrected carefully to avoid cerebral edema. And this is looking at kind of how we would interpret and analyze sodium, just as look and kind of setting us up for what we would be looking for if our sodium, urinary sodium specifically, is off, and what some of the workup steps might be, looking specifically at conditions like diabetes insipidus. So when we're looking at hyponatremia, we can see here hyponatremia occurs when sodium levels fall below 135, and causes include Addison's disease, diarrhea, vomiting, diuretic use, SIADH, and even excessive water intake. It may also be seen in chronic renal insufficiency, hyperglycemia, ascites, or even congestive heart failure with peripheral edema. Because sodium drives water balance, hyponatremia almost always reflects an excess of water relative to sodium. Hyponatremia can be classified as depletional or dilutional. In depletional, sodium is lost through diuretics, vomiting, diarrhea. In dilutional hyponatremia, water intake or retention overwhelms sodium concentration. Examples include renal dysfunction, SIADH, or congestive heart failure. Differentiating between these types is critical for treatment since fluid restriction may help dilutional cases but worsen depletional cases. With dilutional hyponatremia, kidneys fail to excrete water properly, often due to excess ADH, and this can happen in severe CHF, cirrhosis, or renal failure. Even excessive sweating followed by overhydration with pure water can trigger it. Hyperglycemia can also cause dilutional hyponatremia as glucose pulls water into the extracellular space. Understanding this mechanism allows us to target therapy appropriately. Hyponatremia will primarily affect the nervous system. Symptoms include lethargy, headache, confusion, and seizures. Muscle symptoms include cramps, weakness, and fatigue. And GI symptoms such as nausea, vomiting, and abdominal cramps are also common. Severe cases can progress to coma and death. And the underlying problem is cerebral edema caused by excess water entering brain cells. And this is looking at kind of what we would do to understand and work through hyponatremia and kind of how we would work up this condition state.